Saurabh. So, this is with the introduction. Again, I would like to welcome all the people who are joining us today on this virtual platform. So let me start with Patabi sir, our lead expert. Sir, what do you feel as the pioneer? What does the interventional pulmonology incorporates, and what is new we are looking forward in field of IP in coming years? A little wide topic, but I wanted to hear from you. Sir, you are muted.
Yeah. So thanks, Richa. Thanks for the kind introduction, and hello, everyone. It's an absolute pleasure. The interventional pulmonology, it's a reasonably nascent subspecialty. It's a rapidly growing subspecialty with a lot of interest among young postgraduates as well. So it's basically, who is a pulmonologist, who is an interventional pulmonologist, the distinction is not it's a very gray area here. So basically, there was an attempt to define an interventional pulmonologist way back in 2001. I mean, basically, they just described this specialty as a subspecialty that deals with any minimally invasive endoscopic or even percutaneous procedures that are done for both neoplastic and non-neoplastic diseases of airway, pleura, or the lung. And it involves both in advanced diagnostic and therapeutic measures. So you have so many components, and so you see that if you are an interventional pulmonologist, you're supposed to do minimally invasive, both endoscopic and percutaneous procedures, which we've always been doing to an extent. So it's just more advanced procedures. So that is when we'll have to segregate what is advanced and what is the thing. So the obvious expectation of any trained pulmonologist is he has to go through the pleural procedures, the basic ones being ICD and intercostal chest tube and pleural aspirations. Those are considered basic. And as far as bronchoscopy or airway disease goes, doing a regular bronchoscopy, doing Lavage's biopsies, transbronchial needle aspirations, and transbronchial lung biopsies, that's basic training. So anything advanced than that would be what can technically be called as an interventional pulmonologist. Now, it's a wide variety or a whole basket of procedures out there, both diagnostic and therapeutics, and you can see that there are lots and lots of newer things that are coming up, and so future is quite quite rosy that way. So anyone who wants to get into the subspecialty has a wide array of stuff to do. So when you look at what are the things that needs to be focused and what are the future that you're looking at, we can actually segregate into the type of the areas that you deal with. So you can look at what happens in nodules. Thanks to COVID and to all those data that supported screening in lung cancers, we pick up nodules. So the peripheral lesion is one good area that actually has grown really well, because the previous ones was just the radiologist percutaneous biopsy. Very impressive yield, but less than 1 centimeter is a challenge, and so that is where now the whole area of interest is in. And you have a future of what happens to EBUS, whether there are going to be a lot of miniature EBUSs, and whether it's going to be strictly confined to mediastinal nodes, or are we going to go with the convex probe EBUS to a little lateral parts of the lung, including mid-third of the lung. And you have pleural procedures, and there are going to be a lot of advances in pleural procedures as well. And I think someone is going to be, we're going to discuss about that. And always there is going to be an airway, and when there is an airway, you have both diagnostic and therapeutic interventions, and you have advances, both cold and hot techniques that are coming up. And interestingly, there are a lot of stents that are coming up, which are going to be biodegradable. So there are so many options in airways, in lung parenchyma, in nodules, and in pleura. So I would say the whole field is quite exciting, and not to forget the airway interventions of the obstructive airway diseases like asthma and COPD. So I think these are basically the future that actually any interventionist who wants to get into this field should be thinking about. But finally, for this question, I'd like to divide it into levels which are, more or less, the way you divide the levels into probably the need for the skill set. So there will be a level 1, wherein you do a TBNA or you do a TBLB, you do a intercostal chest drains and pleural thing, and probably a pleural catheter will come in a level 1. And level 2 interventional pulmonology, that is where the real interventional pulmonology goes, will be level 2 will be when you look at mediastinal nodes, which includes endobronchial ultrasound or peripheral nodules, these two, and a medical thoracoscopy for diagnostic procedures. These would be called as a level 2, along with the probably bronchial thermoplasty and COPD things, because these are relatively risk-free, and the companies have kind of made sure that it is not much of a training is required. These are not dangerous procedures, as you, if you will. Whereas the level 3 would be where you have therapeutic, airway obstructions, where the patient has asphyxiation, and then you're dealing with them, and the patient has a potential to die during the procedures, and those require higher level of skill sets, and that is level 3, where you would include rigid bronchoscopy with all the interventions which can cause death during the trachal, and also in the pleural world, you will have a complicated empyema where you will need a lot of training to do that, and it's almost going beyond the boundary and almost reaching a surgical level. So this is what I would kind of give an overview about our field as a recognized subspecialty, with some kind of, I've attempted to make some distinctions based on both the skill set and the regions that you play.
Very rightly and aptly said, sir, and giving these, the divisions, level 1, level 2, and level 3. The problem with the youngsters, especially when we are at the, at the teaching institutes and all, when we get those SRs, they come in with an intention to be an interventional pulmonologist, which I feel is important for any pulmonologist, because it is the need of an hour. If your patient is coming with a central airway obstruction, you should be able to, relieve the symptoms. You should be able to save the patient. I feel that. But having said that, they come with an intention that I will do only, stenting. I will do only this thing. So it is very important to understand that you need to know, you need to correct your basics, you need to have your basics, and then you grow up on that. Right, sir. So, Hari, tell us something about this cone beam CT, which is coming up a little big way.
Wow, thank you, madam, for the invitation. To talk on cone beam, if you see the changes that are happening in IP, especially previously, when you talk on like an advanced intervention pulmonologist, it used to be guys who are doing rigid bronchoscopy, coring, means mechanical debulking, all those kind of stuff. But if you see the shift of intervention, means the advanced intervention, now people who do these image-guided nodule biopsies in the periphery, they are those procedures which actually, if you ask me, they are very soft-skilled procedures. They are considered as advanced bronchoscopists, and also there are societies that are formed based on this. If you talk on cone beam, and also if you see the last 5 to 8 years, the changes that happened in IP especially is mainly towards diagnostic aspects than therapeutics. Therapeutics in the airways, as Dr. Pattabhi was telling, bronchial thermoplasty, all these things have come up, but not up to a number where they are able to exist now. Not many cases, and the data is also not so clear on some of the procedures, especially the COPD spectrum. But if you see the diagnostic spectrum, a lot of lung cancer being diagnosed, new cancer screening programs coming up. Most of the people, especially in the US, they are looking at taking a small nodule biopsy using an image guidance. So if you talk on cone beam especially, it's not something that is new. It's been there for 20 years, where oral surgeons used to do cone beam scans, orthopedicians and intervention radiologists. They used to do different procedures, but it was never utilized. Even the companies did not think of such a procedure can be done for lung biopsy. So it was not actually a company-made project. Some doctors, when the cone beams were not being utilized in some of the hospitals, they just checked it like how it will work on a lung biopsy, and then found that. So what happened all these days was we were all biopsying nodules, and then our yield always stayed at, I don't say, because the available tools are not sufficient. The highest tool what we had till now was radial EBUS to go there and then confirm the lesion. But what happens is radial EBUS has its own drawbacks it has. It's a radial scan, not a very central scan, and then the tip doesn't have an ultrasound also. So these are the problems with that, and then cone beam came into picture. So what actually happens in cone beam is it's like it uses a C-arm fluoroscopy C-arm instead of a multi-detector arm in like unlike in other CTs. And then it can also has something called an augmented fluoroscopy. So once you localize a lesion, mark it, you can bring that lesion onto a fluoroscopy image, and you don't have to repeat scans for every time you try to go and see. So basically, there are two things when you talk on peripheral pulmonary nodules. One is navigation, the other one is image guidance. So when you combine both, your diagnostic yields will go up. But many people think that if you have a robotic bronchoscopy or if you have an advanced navigation bronchoscopy, your diagnostic yield will go up. But actually, that's not. When you combine any of these navigation platforms to one of the imaging platforms, so currently we have cone beam, and also there is something called a digital tomosynthesis that is coming up for those who cannot afford to buy a cone beam. That's called a body vision platform. So you have to combine these two modalities, and then there are certain steps in performing cone beam CT scans. Once you there is a protocol how you acquire the scan initially, and then so the patient comes in the operating room, and then you just put her on the bed, tie her up. And what happened is all these days also the diagnostic yield was not very great because we never thought of anesthesia protocols during biopsying peripheral nodules. That is one thing. And second thing, a lot of atelectasis happens when you intubate these patients for biopsies. So these 2 points were not actually considered until the concept of cone beam has come. So because of atelectasis, what was happening is a lot of false image was coming in radial EBUS, and we were thinking those are the real images, and then biopsying false areas and then getting a low diagnostic yield. So cone beam will help you to overcome all these issues, especially the atelectasis. And also if you see the anesthesia protocols, there is a slight change in anesthesia that's they call as advanced anesthesia protocol for biopsying peripheral pulmonary nodules. So one advantage there is like since we now know that there is a lot of atelectasis and all these things happening, even if we don't have a cone beam, if you apply these anesthesia techniques during our guided bronchoscopies, even using a thin scope, I think the diagnostic yield can significantly go up by overcoming these two things. So you have a planning in cone beam, like you just put the patient. If you allow me, I can show you one video also on how it's actually it's a very simple thing, a little cumbersome in the initial 1 or 2 cases, but once you start to do the workflow will be very, very easy. So this is called a Philips lung suite. This is how I think the future bronchoscopy rooms are going to be. So once you put the patient, the technical aspects of cone beam in the initial 1 to 5 cases is really challenging. It takes a lot. You need to know a lot of things, how you position the patient, how you strap them, because movement should not happen when you do this procedure. So we usually done under general anesthesia. So once the patient comes on the bed, you do an initial scan and then acquire the scan onto the workstation. So once you acquire the scan onto the workstation, localize it. All the steps what we do are as same as with the currently available navigation platform techniques only. Here what we can do is like a CT scanner. In all the planes you can mark the lesion, the boundaries, and then transmit that into a fluoroscopy image. This is called augmented fluoroscopy. So every time when you go on, just press your foot pedal and then try to see that you try to guide your bronchoscopy towards that lesion. The problem again with India is now we don't have tools that cross the bronchus. I mean, we have the conventional TBN and needles, but we don't use much of them. That's why even the diagnostic yield of peripheral nodules are less. So that is one thing we also need to add up. Just having a cone beam doesn't add up to your diagnosis. You need to have some tools that can cross and then go beyond the bronchus. So that is one thing. And then in the last 2 years and 3 years, a lot of papers have come, and then you can see, and then once you take you just get your biopsy tool there and then do one more CT scan spin and then see whether your tool is in the lesion or not. It's a basic simple thing if you say whether to confirm whether the tool is there in the lesion or not. So that is the concept of cone beam scanners. I hope I answered your question.
Yeah, I think that was really nicely explained, and with the picture on, I'm sure the people haven't got that. So it's just combining two or three technologies. It is not a big deal. And as you rightly said, it was available. It is available at many places. I think neurology, neurosurgery people are using cone beam CT quite a bit for precision surgeries and all. So it's a matter of. So, what do you feel that are we ready in India? I know there are systems in place in India. With the cost involved or with the time involved, I think it takes 2 or 3 hours for initial first 2 or 3 cases. You need to put up everything. I don't have any experience in that, but that's what I've heard from Dr. Prince, who is doing it. So, are we ready in India for cone beam CD guided biopsies? The cost, how's the cost and
Yes.
other things?
See, why not be ready in the sense like what are we lacking in doing things like, see, I'll tell you one thing. It all depends on where the workplace you're working and then how much you are interested, because this is all
Right.
a revenue model. If you look at lung cancer diagnostics, usually the concept is like everybody thinks that I go to an oncology center and then they will send me cases. It's the other way around in my hospital. Like if you ask me, I usually diagnose 18 to 20 lung cancers through a bronchoscopic procedure, and then they go to the oncology from my reference. So the point of contact, first contact is mine. So that patient belongs to me. So the revenue that is generated on this patient, whether he goes to a chemotherapy or a radiation or on a, this is how you need to make the management understand what we are doing in bronchoscopy units, because many hospitals think that pulmonary bronchoscopy things are very means they don't even consider in par with the gastro. But if the management understands this can happen, I'll tell you, I'm successful in buying my own cone beam for a pulmonology unit alone. So standalone cone beams are even a problem in US, but if you make them understand what we are doing, because the revenue that comes on an indirect basis, and you need to keep a record track of all the patients whom we are diagnosing bronchoscopic biopsies, and then especially lung cancer. The treatment of lung cancer is not that easy. If you're working in a corporate, I'm talking. In government, again, they have their own challenges, but I think it's more easy for them to procure these. But again, the staff for them, and then
Expertise.
the time. I don't think an expertise is very much needed, especially 50 cases to 100 cases, what they say, you get your learning curve. Technicality is more than your expertise in these cases, since we only have means we are limited even in those needles. What maybe in the
Right.
next 1 year, I think we have all these things. We are ready. I hope Tinku and Patavi sir also will agree with me. So we should never consider means, see, when we are doing all the procedures, technology should not limit you. Like see, somebody has a new technology, they does it first. That doesn't mean that if they give us the technology first, we cannot do it. So that should not be a limitation, and we should not be in that thought process that India is because every time they tell that India is when I go to this thing also, our people only tell, nobody tells this. We have very great bronchoscopists in my opinion. So we should never talk these things whenever we are in public meetings that India is something low in any aspects, if you ask.
I don't think India is lagging behind in any aspect, and we are doing much better. The only thing which I think we lag behind is what we do. We have population. We are doing quantum of procedures. What we do lack is the amount of publication we should be doing it, which is lacking, and that makes you come up on the screen. Okay, going to more towards precision, I'll ask Tinku. Tinku, what about the robotic bronchoscopy? And are
Thank you.
we ready?
Thank you, ma'am, for the invite. Okay, so just like Hari had mentioned, sampling of peripheral pulmonary nodule and isolated ground glass opacity is always a tricky situation. Okay, and it's a major challenge for the pulmonologist also. We do have various technologies in India, but to be honest, the most popular one till date is CT biopsy. So CT-guided biopsy, I would say the sensitivity is close to 90 to 92% for the diagnostic yield, but the major drawback of the CT-guided biopsy, just like everyone knows, is the high chance of pneumothorax. the rate of pneumothorax is almost around 20%. So here comes the role of various guided bronchoscopic procedures. So as of now, we have the ultra-thin bronchoscopes, we have the radiolevers, then the various navigation platforms and augmented fluoroscopy, which Hari had mentioned. But again, all these technologies are also put together. The diagnostic yield will be touching close to 70 to 75%. So we need to reach that 95 to 100% level. So what we can do to achieve that? One of the major drawbacks of all these guided systems is that when it is put into practice, what happens is that due to various drawbacks, like the patient will be moving around, or due to respiratory motion artifacts, or due to CT to body divergence, that it affects the diagnostic yield. So that's why all these technologies, the diagnostic yield is between 70 to 75%. So here comes the role of robotic bronchoscopy, which is gaining more and more popularity nowadays. So the technique of robotic system was introduced or invented in 1985, and ever since then it was commonly used by the neurosurgeons, then by the neurologists, gastrosurgeons, and so on and so on. But it took close to 33 years for the pulmonologist to get a grasp on robotic system. The first robotic platform was introduced, I would say, in 2018. That is a Monarch platform, and followed by in 2019 by the ION endoluminal system. And then recently launched, the third platform is the Galaxy by Innova Medical. So we have got three different robotic platforms which is available, especially in the US and European markets. Now, in terms of in India, till date, none of the centers in India have acquired the robotic platform. But I strongly feel that either probably Bhattacharya or Hari might be the first person to acquire the robotic system in India and perform it. So we are waiting for that. And in terms of the advantages of robotic bronchoscopy compared to the other diagnostic modalities, that as per the literature, the diagnostic yield is more than 90%. But with a limited amount of literature available, the Monarch and ION robotic systems diagnostic yield is between 90 to 92%, and the newer technology, that is the Galaxy robotic platform, the diagnostic yield is close to 99 to 100%, but the human data is not available. Whatever is 99 to 100%, it is of animal study. Now, in terms of other advantages, I would say that apart from the diagnostic yield, most of these robotic technologies helps in performing various therapeutic procedures also, which I will come later. And in terms of the technical specifications, three systems have got three different technologies. The Monarch platform and the Galaxy uses electromagnetic navigation system, and it is being incorporated, whereas the ION system uses the shape sensing protocol, and then the three technologies has got uses three different sizes of ultra-thin bronchoscopes. So the Monarch platform uses a scope-in-scope technology, where which a 6 millimeter outer diameter scope is being used. Inside that, a 4.2 millimeter inner scope is here, and the working channel of the scope is 2.1 millimeters. Whereas when you take the ION platform, it uses a bronchoscope of 3.5 millimeter outer diameter with a working channel of 2 millimeter, and in terms of Galaxy, it uses a bronchoscope of 4 millimeter outer diameter with an inner lumen of 2.1 millimeter. So the technical specifications are touch different, but again, the limiting factor would be the cost, because cost would be around 6 to 8 crores compared to other technologies which is available right now.
Right. So you did said something about the therapeutics as well. So are we looking at the ablative therapy, more precise ablative therapy using the robotic system?
Okay. Since since the limiting factor is cost, we have to use this technology. Not one of the main reasons why most of these technologies are not so popular in India is because it is used primarily as a diagnostic modality. So we are competing with the radiologists who are doing CT guided biopsy. So we have to use all these technologies and make it cost effective. So in order to make it cost effective, when you're performing or when you're using these technologies to do for diagnostic purpose, along with that, you should be able to do some therapeutic procedures also. So there are literature which is coming up from China as well as from the West regarding the n number of therapeutic options with robotic bronchoscopy as well as other guided bronchoscopic procedures. So we can ablate certain cancers like stage 1 cancer or in patients who are non-operable with radiofrequency ablation catheters, microwave ablation. You can use the photodynamic therapy, cryoablation. Then at times you can do stem cell therapy as well as ablation of the tumor using nanoparticles and viral vectors as well as brachytherapy. So that any number of options of therapeutics are there. Let it be the guided bronchoscopy or robotic bronchoscopy. So the point is that all these technologies has to be used or it becomes cost effective only if we can perform therapeutic procedure along with diagnosis. So we should not limit all these technologies for purely diagnostic point of view. We have to start performing various therapeutic procedures as well.
Yeah, that's really very valid point, and we have to look forward. But Patari sir, any takes on this robotics?
Yeah, Richa, you're saying something?
Yeah, I said any takes on robotic bronchoscopy from your side?
Yeah, okay. So, see, as far as India is concerned, that it can be relevant for any technology will be relevant for at least some group of people. It depends on where you practice. And so no technology is going to be obsolete or no technology is going to be too advanced for our system. But again, it will not be applied for a general public. So you cannot extrapolate that everyone has to have it. And so that is something, that is a distinction, because India is different from all other countries. There is a complete heterogeneity in terms of who pays for the thing and the amount, the economics, the cost economics and so on. So it's not going to go obsolete. Having said all that, as Tinku said, unless this technology is followed. See, imagine a scenario where a patient comes in and you have a peripheral lesion. You do an endobronchial ultrasound, you find out that you already staged and it's N0, and then you go after the lesion, you find out, and then by a robotic or a cone beam or whatever body vision or whatever, and you make a diagnosis, make it on the bronchoscopy suite, so you both diagnose, and if the diagnosis is robust, you can go ahead and treat them in the same sitting using either a microwave or a radio frequency. So you imagine a patient walks into your bronchoscopy suite and comes out with this tumor gone, and you just follow up. How different is that from doing a percutaneous biopsy, wait for the results, come back, do a staging, because you can't really go further without staging if it's in the nodules. I'm talking about very specific, possibly very, very minuscule at this point, but might increase. So these are fascinating stuff. So in that case, for any radial or in a nodulology, that's what they are calling in the nodule clinic is coming up all over the place. There will be relevance for robotics. Having said that, look at the cost. See if your place can afford it and the people that you cater to can afford it, because there is something that's a very significant issue in this country even now. How much ever we say that there are a lot of people who can afford, there is a very, very significant majority of people who cannot afford all this. So have a track for them also. So it's not that everyone has to go through this. Everyone has to get trained. Everyone has to have swanky suites like what Hari has or Tinku has. So you will have to kind of temper down your thinking, and so it depends on where you practice and what is the group that you do. I think specifics, I think Tinku has dealt with in details as far as robotics is concerned. It makes it peripheral lesion look idiot proof. See, there are certain areas that it's very difficult for you to hold there. And robotic does a good job in taking that turn. It's a very difficult turn when you do a bronchoscopy, staying there and all that. So robotics helps you in accessing certain area and keeping that rest steady so that it is not deterred by any patient movement and the patient is like that. So it kind of idiot proofs a lot of what you want to do in a thing which are probably critical, that additional 5%. But remember, with a basic technology like a radial probe EBUS, with a reasonable expertise, you can still match 2/3 of what you can do. These are only for an additional 10 or 20%. So you'll have to be mindful of that.
Right, sir. So taking up, we're talking about the peripheral modules. I would like to ask Dr. Girish, we have quite a bit of navigation systems now in the market. Which one you think is a better? And if we compare between the navigation systems, what is the benefit? I mean, we understand the benefit is certainly there with the navigation system in terms of precision and in terms of the yield, what we would get. But how do you feel? What is your view about how much the system would benefit above the CT guided biopsies for peripheral nodules, or the available, if we combine the bronchoscopic techniques to biopsy the peripheral nodules? Dr. Girish?
So, good evening, everyone. A very pertinent question as when we are discussing robotics and cone beam CT, that peripheral pulmonary regions are a big thing nowadays, especially in the Western world, because after this lung cancer screening trial, and that it was implemented, that now more and more CTs are being done and we are detecting more and more nodules. So we have to sample them as per the Flischner Society guidelines criteria. We have to sample many of these nodules because they may be malignant in a good percentage of patients. So if we, the yield of a CT guided procedure, transcutaneous procedure is still the best. We have some pneumothoraces, but in maybe 15-20% of cases, but they are not serious. So the best thing, if we can do a CT guided procedure, transcutaneous biopsy or FNAC, that is going to still be the best. But if we are not able to do in some settings, like we have a bulla or emphysema around the lesion, especially if the lesion is very small, like less than 1.5 mm, then the yield of CT guided transcutaneous procedure is low. Then the role comes of a bronchoscopic procedure, and we have a series of navigation systems that can guide us to reach the lesion with the bronchoscope. Now, the first came is electromagnetic navigation that came in the market, and all these navigation systems, in fact, they use helical CT, good volume generated CTs and good quality CT scans that will make a virtual bronchoscopic picture while you are doing bronchoscopy, and that you can merge those virtual and real images to guide you to the lesion. So electromagnetic navigation came first, and it was the first study, the Navigate study, showed that it has a good yield, especially when it is combined with the radial EBUS. It gives a good yield, more than 70%. But subsequently the Acquire registry, the big registry from US, that showed that the yield of navigation systems is, especially electromagnetic navigation, is not that good. So, and it is a very expensive technology. Requires for each patient you require this electromagnetic probe that will guide you to the lesion, and especially in isolation, the yield of even electromagnetic navigation or the other systems also in isolation is not the best. So you need other support, like you need a radial EBUS support, you need a fluoroscopy support, or maybe a cone beam CT if it is available. So after electronavigation, then came the cheaper ones, like the first came BF Navi from Japan, which is now no longer used, and then came the most commonly used, the lung path. So now this I'm sorry, call was coming. So this the latest one that is in use and we have a couple of installations in India also. That is a cheaper alternative to electromagnetic navigation, but the thing is that it also uses the same philosophy of generating virtual bronchoscopic images and then combine it with the real images to guide you to the lesion. But the thing is that if you compare the yield in various studies, we have 6 RCTs also on this modality, that they show that the yield with or without VBN, virtual bronchoscopy navigation, that is commonly used. So the yield with or without this is more or less the same. So so you have to be very particular in selecting which particular lesion you want to sample, because the yield of virtual navigation systems are better if they are smaller in size, smaller than 2 millimeters, and then if they are located in upper lobes where navigation by real bronchoscope is difficult. So you have to pick and choose your cases, and after all this, the cost is still a constraint. In fact, what I feel is that we need to have some dedicated, nodule centers in the country, which should have a cluster of technologies that can be used case-to-case basis, and there should be a referral mechanism from various parts of the country to these nodule centers. They have the cluster of technologies, and then after this, in US, if you talk about the most of the centers, the new IP centers who want to purchase navigation systems, they are going for robotic bronchoscopy instead of any other navigation system, because the robotic is like $500,000, and the rest, the VBN, is like $400,000, and robotic has an inbuilt navigation system. Shape sensing is the latest one. So in US, they are going for robotics if you want to purchase a new system. But in India, for most of the centers, robotic as well as VBN is still costly. And until we have, how many nodules we see that cannot be sampled by a CT guided procedure. Most of these lung cancers we see at stage 2B, 3A, 3B. We don't see small lesions that that volume. So I think VBN is still far until we have cancer screening programs and dedicated centers for nodule sampling. We need to pick and choose our devices. Yeah.
Right. Very rightly said, Dr. Silvani. Do we have any take from Tinku or Hari on this? Okay. Sir, what do you feel? Tinku, you want to say anything on this?
Yes, ma'am. So in terms of regarding whether India can afford all these platforms or not, am I audible?
Yeah.
Yeah. So, so in terms of the question, like whether India can afford all these various newer technologies or not, let me be precise. Like, if India can successfully complete a mission to Mars and Moon, then definitely we Indians can afford all these costly or fancy tools. But the major question is regarding whether it is cost effective or not. Just like how Dr. Silvani sir had mentioned, we have to have an efficient lung cancer or a lung nodule screening program or a protocol has to be put in place before investing a lot in all this costly equipments. Because after investing like 6 to 8 crore on a robotic or other guided bronchoscopic platforms, if you're not able to get adequate referrals, then we will be in trouble. So before investing in all technologies, we should have an efficient cancer screening protocol in place. And we should, not every center can afford these technologies. So within a state, maybe 2 or 3 centers should have the kind of these technologies, and the fellow doctors also should be willing enough to refer such cases to those centers. Otherwise, the investment will be a waste of money. So an efficient lung cancer screening program is essential before investing in it.
Hari, do you want to say anything on this?
I agree with all the views, madam. Only thing is, like, see, if you look at means when we talk on India being not able to purchase equipment, I think some of us should also look in engaging with some of the techie guys and then trying to make our own. Because if you look at the robotic bronchoscopy, it's nothing actually. Like it's just like if you just have like your remote car, you just press and then something goes inside. As simple as that. If you see the surgical world, we have now an Indian surgical robot coming in. When you compare to that, I think because if you see last China has already made their own robotic bronchoscopy in a span of 2 to 3 years. And now, in the next 3 to 4 years, I think India is going to have a lot of startups and all. We should also look at some of the groups in IP also should look in that aspect also where we can tie up with some IIMs or something and then try to make our own robot if at all we can't afford those multinational company robots. This should also change the practice.
Yes, that's true. I think we are pretty innovative in every aspect, so why not this? We should be. And the concept of, having a dedicated center for these kind of nodule biopsies, certainly I think it's high time that we should have, because all of us sitting in different parts of the country, or for that matter, we see very discrete cases of those stage 1 or stage 2 for that matter, lung cancers. But if we put together all of them, the number will be certainly huge than what we are thinking in our practice. So that would really good idea if there are dedicated centers and they are all equipped with all the latest technology to
But I think more than buying a robot means but more than means buying a robot, these dedicated centers will be the biggest challenge in the country. Nobody will refer cases properly to those dedicated. That is the main problem for us.
That's true. So I was coming on that only. So in our country, somehow we feel that if I refer my patient to someone, the patient will never come back to me. But I think that the concept is changing, because I feel there is a change in how the patient understands. Whether they are referred to you, they get the diagnosis and they are happy having their follow-ups with the local doctors only. So this was not the case, say, 10 or 15 years back. But now I think it is changing and people know it is difficult. We get all the population coming from Northeast and West Bengal. It's difficult for them to travel, come to CMC all the way, and then keep on coming every time. So I think it will come soon. Okay, Saurabh, so this is a little close to my heart. I wanted to know, is there anything new coming up in pleural diseases in terms of interventional pulmonology?
So, pleural disease, I think the thoracoscopy, the rigid one, has been there for a long time, and then came the semi-rigid ones. So, I think the newer advances which I can think of is the cryobiopsy, which was not there before, but it has come. And the pleural biopsy using a cryoprobe has kind of now become a routine for a lot of people in India as well, but it has not really shown to be very high in. So the risks remain, the bleeding and everything. So it all depends the what is your. So we really use cryo for patients where we feel that our forceps is inadequate. So not as a for everybody. When we take forceps biopsy and then we feel that it's not working well, we take cryobiopsies. So that is first thing. The second thing is the role of pleuroscopy for infections like empyema. So that has also been there for a long time, long debates, VETS, medical thoracoscopy. There's been a lot of studies on that. But eventually the medical thoracoscopy does help for a small proportion of patients which are who are not candidates for surgery, and kind of clearance, pleural clearance or early clearance can be attempted using medical pleuroscopy for centers which do not have a surgical backup or a very good outcomes for poor patient. So I think there are 2-3 things only. We recently did a trial on the equipment, which was the mini rigid equipment which came into the market, and then as compared to the semi rigid, and we found that probably semi rigid and mini rigid were good, but semi rigid had less pain and less requirement of sedation. So but as we have seen that we have moved from rigid to semi rigid for the probably comfort, but the sample size goes down as we go from the rigid equipment to the semi-rigid. So these are some of the things which have come. The next thing for pleural disease is probably the air leak management for pneumothoraces, for COPD with bulla. So those are the things for pneumothorax management, now we have the like silicone blockers or customized blockers or Watanabe blockers, which have improved the lung expansion. But for all the techniques which I have discussed right now for pleural interventions, I feel the key is the proper patient selection rather than indiscriminate use of the technology. And the obviously the new kid, or I would say for a public hospital as we are, IPCs have been there for some time. We use it less often because of the cost constraints, but I think IPCs are going to be a big thing for pleural patients as we go towards more malignancies. Now we have so many patients who are being diagnosed with malignancies, large effusions. So IPCs have also changed that scenario. At least in our hospital, I have been here for 13, 14 years, and the way pleural effusion management has evolved from like a deadly disease to now having IPCs patients who are on immunotherapies and doing well. So probably those are some of the things which have evolved into the pleural space from the interventional pulmonologist. But I would still, the what you said in the beginning, I would totally agree that that we have to become a physician to a pulmonologist or an interventional pulmonologist, and the pleura is nothing different. So for all things, we have to use our brain, common sense, and choose a correct patient so that we don't end up in a complications or those other things.
Tabi sir, any comments from you? Your center is doing quite a bit of pleura. And we are having Arjun next week with us.
Okay, yeah. So I think Saurav has very clearly, appropriately dealt with what is new in pleura, for which you need to know what is old in pleura, and that's pleura is a very important physician's issue. So it's not that you just have a tube you just stick in because you know how to do that. So I think that is true for every aspect of interventional pulmonology, more so in pleura. So you'll have to go through the process, and I think, we have Dr. Arjun, whose special interest is in complicated pleural effusions, and I think we have one of the most aggressive pleural thing. But again, we need to know the background and do what we have to do. And I think quite appropriately he dealt with. Saurav was talking about IPC. IPC is very, very useful. But again, there is an Indian issue as far as IPC goes in terms of handling, the thing. But again, those things are unique Indian challenges which the Indian physicians have to put our brains together and find out solutions. Hari was briefly saying about why not we do that. I think that helps. That actually is very important for most of the technologies, including IPC. I think we could have an IPC which costs around 5,000 rupees. I mean, it's just a stupid tube with a small bit of silicone which helps in keeping it there. So I think we're paying unnecessarily. I mean, I won't say unnecessarily, but again, we can actually circumvent this and make it more Indian, thing. So what is new in pleura? I'm afraid there's not much in as far as pleura goes. I think knowing what is old in pleura is the most important thing. Understand the pleural disease and do as minimal thing as possible. And I think getting all the perspectives as far as new in pleura, there are a lot of DNases and all that. I mean, handling empyemas, preventing it from going to the surgeon seems to be the most important topic here. So whether we do it by medications or we do it by our procedures is still what we have to, kind of run. But I would think that, pleura has distinct levels of training that is important. And very important to understand, there is no undo button in this field of interventional pulmonology. You do something and you create a problem, then it is your problem for life. And this is exemplified in the pleura, especially if you go to tough pleural effusions, create a leak, and then we have a whole bunch of thing coming up. And I like what Saurav said about the persistent air leak. I think that is a very important group. Very underutilized and underappreciated thing is persistent air leak, and I think we have a lot more of a role than what actually we think we have. So I think that is another thing which actually is new. What is new? You will have to see more. COVID has given us a lot of opportunities, a lot of more of air leaks, patients on ventilator, and we've actually had a lot more of things to do than what we did earlier. So I think peripheral or persistent air leak is one important area, which is our domain. Our people have to claim its thing, because we can do a lot more than what a surgeon can do. These are my 2 cents on Plura.
Saurabh, very quickly, we are almost reaching this time, but I have some 2-3 important questions for the audiences as well. I mean, in the interest of audience, but very quickly, I would like to ask you about your take on various bronchoscopic procedures which have come in the management of COPD, like rhinoplasty, we are talking about total lung denervation, or BTVA we are talking about. So what is your take quickly?
Okay, ma'am. So I think we are talking something which is going to come in future that is not yet in India. That is first thing. Number 2, we still don't have a good data for at least rhinoplasty. For BTVA has come in India, obviously, but in my honest opinion, the data which is there for BTVA is not yet strong enough that it can be employed for routine usage. Obviously, the TLD is something which, in my opinion, is something which may change the future of COPD, because that is something harmless, it seems, and probably going to do what we are trying to do with our inhalers or something, the actual problem which is happening for COPD patients. So, in brief, the data is too less to make any, for rhinoplasty, nearly zero data or very low data. For TLD, there are still trials which are there, and larger trials are going on. So it is yet to come. BTVA, we have data, but the data is still, I would say that it is not strong enough. So there is a very small proportion of patients of COPD who would actually become candidates for BTVA. So I would not go into the details of that. So I would just tell the listeners that BTVA is available in India, but at a very, very few centers. It has recently been DCGI approved for clinical trial use in India as well as for the clinical. So that is all from the COPD society.
Thanks, Saurabh. Sir, Pattabhi sir, I want to know, we burnt our fingers with bronchial thermoplasty, right? It came in a big way, and then lots of people are actually suffering a lot here. So what's your take on these newer technologies, the rhinoplasty, the BTVA, and all those things? Should we jump onto these newer technologies, or should we wait for more evidence to come before, we delve into it? I mean, to me, it looks more industry-driven kind of a thing, but I don't know.
Yeah, so there's a popular adage saying that don't be the first person to get it and don't be the last person to get it as well. If you have a new technology. So, there are advantages and disadvantages of getting it first, but, because of the cost, and I think the most important thing is the data and how you interpret the data. Things like bronchial asthma, things like COPD, there is a role for all these technologies that has been, even if I say the bronchial thermoplasty experience, we've done about 15 cases, and there is a significant group of people who were responders. There were some non-responders also, but the reason why the company withdrew it, because there are a lot more of MABs coming up which are going to exactly interfere with the same thing. And also all the data, if you look at the data, it's not an overwhelming favorite that everyone who gets it has a significant thing. So these technologies have to be looked at it a very independent thing. It's always nice to have a central institute taking this up, getting an Indian data, and after that, once we are convinced, and then so that would be the ideal way. Get a AIIMS, PGI, or a teaching institutes like Vellore, or they get it, and then they do the proper thing, and then find out if it is useful. Then rest of us buying. But again, unfortunately, that's not going to happen, and that's not how it works. Also, so for COPD, there's only so much that you can do. And if you look at all the data, you see a lot of European data coming up and not much of American data coming up. All these rhinoplasties, TLDs, the numbers that you see on data are also very, very low. And if you look at the coils and all that, all these volume reduction, bronchoscopic volume reduction, it's fascinating. If you look at the logic, it will be there. If you look at the science, that will be there. But if you look at the data, it is quite disappointing. And that is where we have a problem with. So that's why, and all these are very, very expensive procedures. Okay, at least in COPD world, you don't need to get if it's a coil or if it is a the one-way valve which has the maximum data, which is unfortunately not available in India. Here you don't need to buy anything because it's only the valve that company comes in and the patient pays for the valve, and the procedure is it's all idiot proof, so it is easy to do the procedure. That is easy. But in anything which involves a machine which costs about 1 crore, and then the reusables, I mean non-reusable catheter which costs 30,000, that is where we have a problem with. We buy it, and we have a problem with the bronchial thermoplasty, and I am not too sure how robust the other things will do. So there is always we'll have to be a little circumspect when we go for procedures. Unfortunately, in interventional pulmonology, there were a few game changers in the past, like endobronchial ultrasound. Rebus TBNA was a game changer because previously the yield of TBNA ranged between 30 and 50, and this jacked it up to 80% right away. So there is a huge demand, and this supplied that demand, and so it was quite easy. As against other things where standard of care is reasonably all right, we're looking at the next 5 or 10%. So it's, this becomes market driven in more than one way. So I think we'll have to use due diligence, find out what your patients are, find out what your institute is, find out how much you can, spend, and then that's how it has to be, catered to. There is horses for courses policy is what we'll have to do.
I think it is very important the type of patient, the type of population you are catering. Probably you should plan your procedures and your instrument equipments accordingly. Quickly to everyone, if we could have any training opportunities for the youngsters from the panelist or from Sir in India or abroad, which is easy for them to do. I'm sure there are quite a bit of youngsters who have joined our today, so it's open to everyone.
Yeah, so shall I start? I mean, I'll just say that the best way to learn is when you're a registrar or when you are working as a postgraduate. So if you are doing a training in a place which has all these, I think that is the best way to learn. I mean, rest of it is you will have to make your time. You will have to keep away from a busy practice and try and go. In which case, it seriously reduces. One thing is sure, just observation, you might not be able to do most of these procedures. You will have to do a proper rigmarole, which will be at least 1 year. So unless you are at least 1 year in a place, it would be very difficult for you to call yourself an appropriately trained thing. Having said that, you don't need to get trained in everything. I mean, that's another thing. But again, if you want to be a complete on the top of thing, you'll have to have a proper, going through the proper thing, attending a few workshops, taking 2 or 3 days observership, and being, rounding with someone who's done the procedures will give you a perspective, which is also very important. That will help you get inspired and go into such procedures. But, if you just a couple of weeks in a high volume center will give you a perspective. Most important thing in interventional pulmonology is not only about the procedures, but it's also about decision making. And for that decision making, you'll need a fair length of time to be staying. Second thing is handling complications. You can do a stent looks beautiful, and what happens in a month's time and how you handle that will not be seen when you are just rotating for about 15 days. So that is the most important thing. Doing the procedure is just a start of a solution, but it is also a start of a problem. And how you handle complications and all these are there. So for training, I would suggest you will have to, if you're not trained during the post-graduation time, you will have to set aside at least 1 year if you want to be serious in this business. Otherwise, getting a perspective or concentrating only on one particular aspect, which is quite okay. If you want to do only a pleural procedure, I want to do only pleura, I'm not going to do a lot of rigid work and all that, it's perfectly fine. In which case, you can cut down the time that you spend, go to a high volume center, be there. There are enough centers that are offering fellowship courses, and now I'll leave it to other esteemed panelists to add on to what I've just said.
Okay. So back in 2012, when I had this passion towards IP, and when I decided to get trained in IP, there was barely any centers which was offering any sort of training programs. To be honest, I guess at that point of time, there were 3 or 4 centers in India who are doing predominantly IP work, but most of the centers were not having any, not ready to offer any sort of training. So we had to, I had to go abroad and get trained. And just like how Pattabhi sir mentioned, it's not about the skill in learning procedure. You have to know how to manage the complications also, because initially I thought of a short stint and of 6 months I did the training, and towards the last day of my training, my mentor did a tumor debulking, and it was a carrying tumor. The tumor fell apart and started to bleed, and the patient unfortunately succumbed to the illness due to the major life-threatening bleed. So on that particular case, my mentors said that you have learned in the past 6 months, you have seen various procedures, you have done rigid intubations, but now you have seen a major complication. So it's not only about learning or spending time in the bronchoscopy suite, you should be able to tackle the complications, and decision making in the bronchoscopy suite is very, very important. That's why I strongly feel, just like how Pattabhi sir mentioned, 1 year of rigorous training is required in interventional pulmonology from a dedicated large volume center. And I also strongly feel that preferably if you have some amount of critical care training in ICUs, it makes rigid intubations and all those things much more easier. The people who are having some amount of ICU training, they'll be much more rigid, and their decision making capacity will be much better compared to a person who is not trained in ICU. So 1 year of training is very, very important, and you should know how to tackle complications, and preferably you should have add-on exposure to ICU as well. And in terms of the various training centers in India, as of now, there are close to, I guess, more than 10 institutes in India are offering both short-term as well as long-term fellowship programs. Hands-on fellowship programs are there, and compared to the situation which was 10 years before. And there are certain Southeast Asian countries also which are ready to offer hands-on training. So I would say that whosoever who's planning to join for IP training program, do 1 year of program, as well as before joining for a program, make sure that you should have a center to come back and join, because after completing the training program, and if you don't have a center with all these facilities, then again you'll be coming back and practicing as a general pulmonologist. So prior to going for any of this program, make sure that you have a job in hand with an equipped institute.
That's true. That's true. Saurabh, Dr. Girish, do you want to add on?
Hi, ma'am. So I would say, like, we have a DM program running, which is a 3-year program post MD. So we have intentionally not started a fellowship in IP, and the reason being that we believe that we cannot separate IP from pulmonology. So we have residents who are being trained in pulmonology, ICU, and continued in the various levels of the IP, which are mentioned from level 1, level 2. So most of our residents who are post DM, they reach level 2, but obviously the level 3 does require something which is beyond that 3 years. Means in 3 years you cannot learn pulmonology, sleep medicine, critical care, IP, the entire thing. So probably level 3, you need to go beyond it, whether you do it in our center, whether you do it in another center, but that requires something which is beyond. So there are centers which are providing IP fellowships. So if you are well trained, at least till level 1 during your MD or DM or your SRship, probably that's when you should reach beyond it and go for a fellowship program, I would say. And the duration, the dedication you have to have during your program is extremely important. And what means, I have been in pulmonology for 10 years when I joined my DM course, and over the last 10 years we had everything starting from 10 years. And what I have learned is handling the complications. So if you do not know that, do not do it. If you don't know your plan B, if you have not learned it through your mentor or seeing them while being there, then you may end up in a problem. So the duration of training is extremely important, with dedication, follow-up of your patients, what is happening to them after the procedure, maybe 2 weeks, 3 weeks, 1 month, 2 months. So that's where you will learn that what I did wrong or what I did right was when you have your own follow-ups. So that's very important to have a follow-up of your procedures.
So agree with everyone. We actually in our country we do have a demand supply gap. It's a huge gap. We need a lot of more IP centers in the country, and for that we need a good training opportunity, training centers. But the training opportunities for us are really limited. Even if, as Saurabh told, that even after completing your DM, you don't have any experience with level 3 procedures. So yes, there is a demand supply gap, and many of the IB physicians they have to go to Middle East or other countries to get training, and we centers like AIMS and they should come forward to start fellowship programs for physicians who have completed their post graduation. Then only the scenario can change. That's my thing.
Hari, you want to add on something? You are offering the course, I believe.
Regarding training, if somebody is asking like where to go for training and all, if you really somebody is interested, they will find out where to go. You don't have to advise them, because see, that's how we did it. Like if you're really interested in learning something, you're not at school level or an intermediate level to somebody guiding you on going and joining. So you need to find out where the procedures are being done, how the previous students are passing out, what is their level of competency, how those students are faring when they come out of your fellowship. All these points you need to look into and then get into those training programs. That is, and I don't advise people you go here and there. Second thing, when it comes to training, you should never train in one center for a year. It is very, very wrong. You need to see 2 or 3 big volume centers, see practices what they do, because every IP setup is different and every doctor, they have their own skills of performing intervention procedures. So you need to rotate in 2 or 3 centers and then try to acquire skills, because every center cannot be a great center for one procedure or all the procedures. In some centers, like if you ask National Cancer Center in Japan, Radial EBUS, it is the center of excellence. At least a 15 days training there will help you to understand all the aspects of radial and convex EBUS. Like that, you need to understand where the training is happening. I hope Tinku will agree on this with me.
Okay.
Thank you.
And,
I'll just quickly, Tinku, you want to say something?
yes, yes, ma'am. And one more thing is that certain procedures, it's like let me be, it's my own story actually. Certain procedures we tend to learn by experience, because back in 2016 when I started this IT practice, at that point of time I had a lot of adrenaline rush. Let it be any central airway tumor, I tend to consider that I should debulk it. But back now, I mean, like after 6 to 7 years of experience in IP, right now I have that decision making capacity has improved compared to when I was like 6 years before. And the reason is that even the reason why I mentioned about central airway tumor is that not every tumor has to be debulked, because if there is no distal airway, if the underlying lung is collapsed or destroyed, we are not going to achieve anything by doing a debulking procedure. So the reason why I mentioned this example is that certain procedures you learn by experience also. In spite of 1 year of rigorous training in IP, you may not be able to be 100% perfect. That perfection level improves with the experience you gain.
Right. So we are almost ending. I'll quickly take one question by Dharmesh Shah. He's posted that why would you need an airway route approach for such far out peripheral lesions? Transthoracic needle aspirations or biopsy is a more easier approach for such a lesion, as shown.
So the answer is pretty simple. I don't know who has raised that question. So the person who has raised the question, just consider yourself as a patient. Okay, if you have a peripheral pulmonary nodule and if you have got the facility for all this bronchoscopic technology, will you go and undergo a CT guided biopsy? And if you can perform a bronchoscopic procedure and get discharged on the same day, will you go to a radiologist and undergo a CT guided biopsy? And the chance of pneumothorax is 20 to 22%. If you end up having a pneumothorax, you'll have to stay in the hospital for another 1 week, get a chest tube in situ, and wait for 1 week. So the question is that put yourself in the shoes of a patient and consider that if you suffer from a lung nodule, whether you will opt for a bronchoscopic guided approach or a CT guided. So the cost, if you develop a pneumothorax, is going to be very high compared to a daycare procedure. So I would say that if there is a center which is there nearby, which has got the additional technology, I would prefer to go for a bronchoscopy guided biopsy rather than a CT guided biopsy. But if the nodule is so peripheral and if it is abetting the pleura, that the chance of pneumothorax is very minimum, then I could go for a CT guided biopsy. But if the lesion is away from the pleura, then I would go for a bronchoscopic procedure.
Okay, if I can add on that, since Dharmesh is not there to defend himself, I would try and see what Dharmesh can say, and I think there is a lot of science in what Dharmesh feels also. The idea of having a nodule is to making a diagnosis. The idea of doing a procedure is to make a diagnosis. Now, so you can do it the way you want. If you are trained in a CT guided biopsy, Dharmesh is one person who actually does a proper CT guided biopsy himself and doesn't. I don't know how, but he keeps the radiologist away and he does it in his own inimitable way. And I do agree when he says that the amount of pneumothorax is lesser than what is quoted in literature. I would still agree with that, excepting if you have a lot of COPD in that area, and if you have a emphysema in that area, obviously we're not going to touch that. But having said all that, if you just have to make a diagnosis, is the only key. And if the patient is willing to go through this procedure than that, I think there is also a difference in the yield, which is 90% versus 50 to 60%. So you have a lot of things in play. If you have a lesion which is big, if you have a bronchus sign, I would say that I would do a peripheral lesion through a bronchoscopic mean. If there is no bronchus sign, if you are neither here nor there, and if it is very accessible, not close to the diaphragm, then I would still find a merit in sending him to a CT guided biopsy if the patient wants it. Again, if you are in a setup, if like us, where we would like to put in a bronchoscope at every time we have this, I would fully agree with Tinku. I would also go with that thing. But if there is a setup which can do the similar thing, I would see no reason why they should not be doing it. So let it not be that we cannot do that. Even that is also another way of making diagnosis.
I think you should take the next question by somebody posted there. Funny questions.
What is that one? You want me to take that?
One more thing that
Yes,
I was
yes,
not aware that
please,
this question
please.
was raised by Dharmesh sir. Probably I'm expecting a call from him.
Dharmesh, yeah.
I was not aware that this question was raised by him.
So I think we are overshooting. Hari, you want to take that question?
Yes, yes.
Okay. So how much of the learning is based on social media posts by self-styled experts?
No, see, I don't know, because that's targeting someone. Let me answer, like, see, procedural training, you read 10 journals and then you can never do a procedure. That's what happened to all of us all these years in this country by not showing how a procedure has to be done on a video format. Understand? So please understand that point. So people learn procedures by seeing the procedure directly in the operating room or by doing a video and studying how it is done. So that is the purpose of educating on a platform. So if you read an up-to-date on a central airway obstruction, none of you will be able to do the procedure in the operating room by reading something or writing some journal. If you are a good statistician, without doing anything also you can write numbers. What is the proof of that? So that is why we are trying to create a video format and also an up-to-date based on procedural learning from start of the procedure till the follow-up of those patients, where you make them cure. So this is what is needed for the future generation. And the technology is evolving and the generation is evolving to digital technology. You don't study papers or textbooks now, you just read on iPads and all. That is how the education should be. And there is nothing like, nobody is telling by themselves they are experts or anything. You people are commenting like that. That should not happen. Did anybody write a paper saying where somebody is a self-styled expert? That should not happen in anywhere. I don't agree with those kind of things. Whomever they are looking at and telling, that should not be happening. That is why I think the IP in this country is at this level even after this many years.
No, I think I agree with you, Hari, because visual knowledge is certainly much grasping, and you know how the things are. Just reading the journal, IP is totally different ball game. It is not, you know, writing an MD exam where you read and you put it up. IP is certainly different. You need to observe. You need to have the thing. You have to have it in your mind what you are seeing, what you have to do. So certainly, I myself feel that these procedures do help me when I see the videos. They help me. They help me to see how I would look a procedure into. I get an aspect, I get a perspective of another person. So I may think it, so how do I do it? I see that and I think myself how I would have done it. And you know, so it is always good to actually interact and always good to see through it. And I'm personally benefiting quite a bit. So I landed quite a late into central airway obstruction. If we talk about, I was very happy doing my pleura, but things turn out in a way that I have to jump into central airway obstruction and all those things. So I do get benefit quite a bit. So, so no offenses to anyone, Hari, Chinku, and Saurabh, Dr. Grish, Sir, everyone. You all of you are doing a good job, yeah. So don't take any offense and just keep doing the good work, keep doing your teaching activities. Sir, for you, we are crossing 20 minutes. I'm really sorry, but it has become so interesting and so nice. I just wanted to ask you, has the IP field expanded so vastly that you feel that one person cannot do all the procedures in IP? And is it the time to focus on the specific domain, be it pleura or PPNs or parenchyma or likewise? The last comment from you, sir. Or we have to wait another 5 to 10 years.
Okay. So, yeah, the good thing in IP is that you don't need to learn everything. You know, you can be a master in pleura, or you can be master in, you can, you know, likewise, you can, I mean, I would give certain perspectives, which is you don't need to do everything. No, you don't need to be in charge of every thing. You can learn certain procedures and rest of it can be done on the job. You know, like you start off being one thing and you can actually graduate to slowly becoming other by attending and doing all that. You can grow on the job, but you need to have certain perspective. That's why I always say you'll need good perspective in decision making. It's not about, IP is not about doing the procedures. IP is about knowing perspectives. And certain procedures obviously need a MDT. It's not you alone who's going to decide about the procedure, especially when it comes to a transbronchial cryobiopsy in a setting of interstitial lung disease. It has to be done at the context of a MDT. Likewise, it's in a severe asthma clinic or in a COPD clinic. I think the decision to do procedure would come out of an MDT rather than in a patient coming in with the V's and so you trying to sort this out by doing this, or a patient having a CT what vaguely looks like an ILD and so I'm going to post for a TPLC. I think that there has to be a rigor in time of thing. As already we've been discussing, the training must be adequate in what we have to get trained. So, I mean, as I said, you don't need to be level 1, level 2, level 3 at the time that you start your IP clinic. But I mean, to have a reasonable start, you need to have an adequate training. And the most important thing in an IP is team building. You will have to. It's not that you are all alone and you will do everything. No, even if you are having a very just the plural services. It's not enough to have one person doing it and others not knowing whatever that happens. So you'll have to have a team. The team includes the group of people. So you can go to another place and while the IP is a 24/7 thing, you know, you drop a stent now in a Monday morning and then on a Saturday evening, the patient comes with a stent blocked. I think it's your problem, not You can't say that you can go and meet someone else. So there has to be a 24/7 clinic of IP. You'll have to have people on. I think most important thing, and these people are worth their weight in gold, is your bronch assistants and the nurses in the bronchoscopy suite. It's very important that you have most of these things. So the most important thing is to have a adequate training. The most important thing is to make sure that you get decision making right, you handle complications well, and you have a team of people who can actually give a round the clock service. I think these are the things that you'll have to look for. Forget about the individual procedures. If you want to get into IP, you'll have to have these characteristics. It's not like have a 9 to 5 and a weekend is yours. That cannot happen. And I think I can talk on behalf of everyone sitting in this panel that we all learned it the tough way. We had to start off initially as standalone people. We developed a team. So developing a team not only includes the team of doers, the team of helpers. Those are the most important people. Set up a good team and be in this field. We had a disadvantage, which also was an advantage, because when we started doing it, there were not much of people who were telling us how to do it. But now I think we have experts both here and elsewhere who can actually guide us. So everyone is a phone call away, so we can always call any one of us. I'm sure Hari or Tinku or Saurabh or Girish would be very happy to give whatever insights that you would want. And not to forget Richa, who acts very as though she's a student, but she's actually a very good interventional pulmonologist. So all of us have gone through the grind, and I think most important is go through the grind, handle complications, get a perspective, build a team, and that's all matters.
Rightly said, sir. And not to add, probably they should learn when to say no. Right? That is very important. I would like to thank you all with all my heart, the way the discussion has gone and the way we have interacted. I'm sure this was such a lively discussion where everybody just put their soul into it. And that is probably because all of you are the people, you are passionate about your field of interest, and that is what makes you stand apart from anyone else. Thank you so much once again for joining this webinar, and good night.
Good night.
Good night. Thank you, ma'am. Good night, everyone.
Thank you. Bye. Bye, everyone.